Okay, let's go ahead and do the Unit 9 recap on cardiovascular disease. First of all, I want you to start off by reviewing some of your cholesterol values. To know that the HDL, we want it to be greater than 40, the LDL less than 100, and the total cholesterol level being less than 200. Also look at your lipids. We want lipids to be less than 150 for men and less than 135 for women. In doing assessment and listening for how it sounds, make sure that you know what you're listening at with certain placements. So do review your placement. We know that when we place a stethoscope on the second intercostal to the right of the sternum, we are listening to the aortic valve. When we place the second intercostal to the left of the sternum, it's the pulmonic valve. And then we have Erb's point, which is the point where we have the maximum sound of the S1, S2. So it gives us the best S1, S2 sound. And that's going to be the third intercostal to the left of the sternum. The tricuspid valve is listened to when we place a stethoscope on the fourth intercostal space left of the sternum. And then we know, of course, the mitral, also known as the apical, is the fifth intercostal space mid-clavicular. Make sure that you review teaching, lifestyle changes, healthy heart. No matter which cardiovascular disorder we are studying, we're always going to go back to that core teaching for our patients, all right? Which would be when we look at diet. We know it's going to be a low-fat, low-cholesterol, low-sodium diet. This is a heart-healthy diet. We're going to teach them about moderate exercise, to do it regularly. Also with moderate exercise, we know that this increases the HDL, so we do want them to have an exercise program. We want them to increase their omega-3s in their diet to maintain a healthy weight, to manage their stress, and of course if they smoke, to join a smoking cessation class, or talk to their provider about quitting smoking. Okay, so let's go ahead and start off with hypertension. What is it? When we talk about hypertension, we talk about a persistent elevation of systolic or diastolic blood pressure, or both of them. We know that we have risk factors for it. Some of them are non-modifiable, such as family, age, gender, and ethnicity. But then we have a whole lot of risk factors that are modifiable, such as diabetes, stress, smoking, obesity, the diet. If we have a high-fat, high-sodium diet, we can certainly modify that, and we can modify our cholesterol levels. So what does it look like? When we talk about hypertension, we talk about several levels of hypertension. We know that the parameter for diagnosing hypertension is a systolic of 140 over a diastolic of 90 or above. We know that we do not diagnose it with just one reading or even two, that we have to trend them to make sure that it is persistent elevation that is existing. We also have what we call a pre-hypertension state, which identifies those people that are at risk. If you are diagnosed as having pre-hypertension without any intervention, you will progress to developing hypertension. So pre-hypertension is when we have a systolic that is anywhere between 121 to 139 and a diastolic anywhere between 81 to 89. We know, of course, that the normal hypertension we defined as 120 over 80. So if somebody has hypertension, what does it look like? We know that it's a silent killer. Oftentimes, there are no symptoms whatsoever until the patient maybe strokes or has an MI or comes in with seizures or something like that. Or it's discovered because they go in to see the doctor for some other event. And doing the checkup, they discover that they have hypertension. The early symptoms, as it progresses, actually can be headaches, fatigue, dizziness, flushing. We can have some nosebleeds, some blurred vision, maybe some palpitations. But oftentimes we kind of just dismiss it because they come and go. All right. So from no symptoms to some symptoms that oftentimes we dismiss. So what are the complications of hypertension? Well, like I said, MI, stroke, nephropathy, heart failure is another one, and of course hypertensive crisis. What do we mean by malignant hypertension or hypertensive crisis? Malignant hypertension is a grossly elevated high blood pressure. And of course, the hypertensive crisis is that grossly elevated blood pressure coming in with signs and symptoms that are life-threatening. Okay, so we have a severe increase in blood pressure with hypertensive crisis, and the diastolic normally is greater than 130. This crisis may lead to stroke. There is organ damage occurring with a hypertensive crisis. The patient may develop left ventricular failure. Signs and symptoms will be restlessness, severe headache, agitation, combativeness. They may come in comatose. They may come in having seizures, or they may just be complaining of dizziness. They may have nausea and vomiting. If they are vomiting, it's usually projectile type vomiting, and of course they'll have some visual changes, some blurred vision. We need to intervene. These are the types of patients that show up in the emergency room and end up in the ICU, and we are giving them potent antihypertensives IV. So what is the treatment for hypertension? Okay, the treatment revolves around diuretics. They can be potassium or not potassium sparing, so keep that in mind, that if we have a potassium sparing diuretic that's being administered, either one, we're going to monitor the potassium because we do anticipate that the potassium may increase. If we have a non-potassium sparing one, then we know, of course, that we need to monitor the patient for signs or for evidence of hypokalemia. So either way, we're going to be monitoring potassium. Beta blockers, which will decrease the heart rate and dilate blood vessels. ACE inhibitors, which by blocking the angiotensin, they block the vasoconstriction that occurs and results in vasodilation. And it also results in the kidneys excreting the sodium and fluid. We have calcium channel blockers, and we know calcium channel blockers are chosen for individuals that cannot tolerate beta blockers, such as people with asthma or depression. So the calcium channel blockers are going to slow your heart rate, and they are going to dilate vessels. And then we have lifestyle modifications. The DASH diet is employed, which is a low sodium, low fat diet, particularly the sodium. Make sure that you do teach them about potassium. It's important that if they use salt substitutes, that they realize that they are substituting potassium for that sodium. So it's important with their diuretics that we teach them to monitor that. We're going to have them do moderate exercise, weight reduction, smoking cessation. Okay, the next one on here is the PVD-PAD. PVD stands for peripheral vascular disorder. The PAD stands for peripheral arterial disorder. They are one and the same. So what is it? It is obstruction of the large arteries, not within the coronary, aortic arch, or brain. Okay, so when we talk about PAD, there are 6 classifications for it. We have mild claudication, moderate claudication, severe claudication. The severe claudication is pain at rest. The mild and moderate is pain that occurs with walking and subsides with rest. And then we have ischemic pain at rest, progressing to minor tissue loss, and then the last one, major tissue loss. So these are the classifications of PVD-PAD. Now, intermittent claudication is exactly that. It means that there is pain with walking, which is relieved with rest. Now, it is important that somebody has, if we have a patient with PAD that has intermittent claudication, an important piece of the treatment would be an exercise program for them, a walking program, because we do want them to walk. In doing so, they are forming vascularization, all right, so of the extremity. So we do want them to walk. All right, so what does it look like? All right, claudication is one of the pieces there, the pain with walking. If it has progressed severely, then they're going to have pain at rest. We're going to have decreased pulses. The patient may have sores or wounds that are slow to heal or don't heal at all. There's going to be changes in color to the extremity, either pale looking or bluish looking, diminished hair growth or no hair growth at all. The skin will be shiny and flaky, and of course they will have a sluggish capillary refill. When we do elevate the extremity, these symptoms are aggravated. They are intensified. So how are we going to treat it? Medically, we're going to have medications. We know the walking program, and then medications that are going to promote arterial flow and reduce viscosity and dilate the blood vessels. We're also going to reduce clotting ability of the blood. Surgically, we can do bypass surgery. Femoral popliteal bypass is an example of one of them. This is for revascularization. Please remember that whenever you have a surgical intervention like the FemPop bypass, that we do need to conduct neurovascular checks of that extremity. We want to monitor and make sure that our circulation is adequate and that we don't have nerve compression or nerve damage. So neurovascular checks are important. What is it that you monitor with neurovascular checks? You're going to check the temperature of the extremity. You're going to check pulses, sensation, okay, whether they have pain, numbness, or whether it feels like pins and needles. Whether they have, we ask them to wiggle their toes to see if they have pain, increased pain with their toe movement of their toes. And we're also going to monitor for any swelling. Sort of like what you would monitor for with compartment syndrome. All right, so post-operatively, it's important to do this monitoring. Now, the other type of surgical intervention would be an amputation. An amputation would be done when, of course, we have tissue damage. We have tissue loss. And so the amputation may be any part of the extremity. All right, so when we do have an amputation, remember that we want to take care of that stump. Initially, for the first 24 hours, the stump will be elevated on pillows. We do want to make sure that we reduce the chance of having a flexion contraction of the hip with the extreme elevation of that lower extremity. And so when we do have them for those first 24 hours, we make sure that about every 3 to 4 hours we do lower the leg. We put them in the prone position and for about 20, no more than 30 minutes. And this is to reduce the chance of a flexion contraction occurring of that affected, of the hip on that affected limb. After 24 hours, barring any contraindications, then we're going to lower the stump to a prone position, to a flat position. And that's because, remember, it's going to promote circulation to that stump. We want that. With PAD, remember that we want our extremities in a dependent position. Anytime that we elevate them, we're going to aggravate the condition. With the amputation, then of course we want to teach them about phantom pain and treat the phantom pain because it is real pain. And then we're going to teach them, and we do it ourselves too, of course, how to dress the stump so that we shape it. We're shaping it for the prosthetic device. And then they're going to require rehab, of course, to learn how to walk. So we're going to have gait training and then training when they're walking with their prosthetic device. Other complications from PVD and PAD, of course, we say that if you have PAD, more than likely you have CAD, coronary artery disease. So we can have that. We can have a myocardial infarction from that as a complication, or carotid stenosis, which of course would lead to stroke. We may have an atrial fibrillation or renal disease with PAD. Okay, next on here are two conditions that we put here under cardiovascular: Buerger's disease and Raynaud's disease. They are not common disorders, but we do want you to know them. So Buerger's disease, what is it? It's an uncommon occlusive disease of the arteries and veins in the distal portions of the upper and lower extremities. The cause is unknown. There is a strong association with smoking. So what does it look like? We have ulceration, maybe even gangrene in the digits. We will have decreased pulses. The skin will be cool to touch. It may be red or cyanotic, actually, when you place those extremities in a dependent position. How is it treated? Very simple. The treatment, because of that close association with smoking, it is smoking cessation. Stop smoking and it results. Raynaud's disease is a vasospasm. We're referring to vasospasm of the arteries in the upper and lower extremities. Again, the cause is unknown, and it does affect the superficial skin vessels, which constrict. It may be genetic, we don't know. This constriction, of course, is going to be aggravated by cold or stress. So what does it look like? We're going to see digits that are blanched, and they may be followed by becoming cyanotic, cool, numb, or painful. There may be some swelling. So what do we do with Raynaud's disease? We teach them to avoid cold stress. So covering their hands and feet when they're out in the cold is an important part of the treatment. DVT is the next section on here. What is it? We know that DVT is a blood clot that forms in the deep vein, most often in the legs, and it usually forms near the vicinity of the bend of the knee, all right? Either right below the knee, the bend of the knee in the calf, or right above it on the thigh. So risk factors, whenever we suspect somebody with a DVT, risk factors play a significant role, especially immobility, whether immobility from illness or from major surgery, from long travel. So when we have a person that we are working on, we suspect a DVT, we're going to assess to see if they have immobility and what was the cause, all right? But other risk factors can be hormone replacement, smoking, birth control pills, obesity, previous DVT puts you at risk, varicosities also put you at risk, and a family history. We do know that when we do the assessment, the more risk factors that you have, you're higher risk for a DVT. But most often, the most common cause is immobility. So one of the things that we do whenever we, we have control over immobility, we take measures to avoid it. So that means if they're in the hospital for a major surgery, we're going to employ early ambulation, and we're going to apply either compression stockings or more significantly apply the sequential compression devices. And then we're going to start them on low molecular heparin prophylactically. Now, if they're going to be going on a long trip or anything like that, we teach them to interrupt their trip. If it's a car trip, then stop every 2 hours, get up, walk around. If it's a flight, for them to get up and walk up and down the aisles, go to the bathroom, but not to remain in a sitting position for a prolonged period of time. And then, of course, if we have somebody that's immobile because they have medically, or they're confused, or they're comatose or something like that, then we know that we need to make sure that we do have those compression devices in place and that they are on low molecular heparin prophylactically. So what I'm saying actually is that the best treatment for a DVT is prevention. So if somebody gets DVT, what does it look like? We're going to see swelling of the leg or along the affected vein. It will be painful or tender to touch it, or just with movement. Especially with standing, it'll be painful. It will be warm to touch, and it may be reddened. The skin may be reddened the entire leg or just along the vein. How is it treated? Like I said, prevention. TEDS, SEDs, ambulation, Lovenox. So that's the key. But if we have a DVT that occurs, then we're not going to do Lovenox. We're going to do heparin. All right. And usually we start them on heparin drips. The heparin, the intent is to stop the clot from getting bigger and to prevent other clots from forming. Of course, once they have the DVT is diagnosed, we do not want them to get up and walk around, because that's when the clot dislodges and it will travel to the lungs, causing a pulmonary embolism. Make sure, whenever we do have them on heparin, we're going to do PTT, so that we can go ahead and make sure that we have reduced the clotting to a sufficient level, so it's a bleeding time, and we want it from 1.5 to 2 times the normal time. Normally, a parameter that we use is for us to report it if it's greater than 70 seconds. So report it to the doctor if it is greater than 70 seconds. Okay, coronary artery disease is the next one on here. What is it? Well, coronary artery disease is a narrowing of the coronary arteries, which occurs from the fatty deposits in those arteries as a result of atherosclerosis. So the risk factors would be a high cholesterol, high blood pressure, smoking, obesity, a sedentary lifestyle, stress, and diabetes, age. What does it look like? Well, you could have no symptoms whatsoever, or you could have some. Usually it's angina. You may have some shortness of breath or fatigue or lightheadedness or some palpitations. Oftentimes, coronary artery disease is diagnosed when a person then has the complication from it, which is a myocardial infarction. So diagnostics include, there are many, all right? So the diagnostics are going to be intended to see what is the degree of the occlusions, all right? So of course it'll include an EKG, echocardiogram and scans, a stress test, blood work, especially cholesterol levels, and then the big one is the cardiac catheterization. Cardiac catheterization diagnostic will tell them exactly where the occlusions are, the degree of the occlusion, whether it's operable or whether they can do interventional cardiac catheterization, whether they can right there on the spot repair it. All right. So if they do interventional cardiac catheterization, that means that they have taken actions to open up the blood vessel or the coronary artery that is occluded and restore the blood. All right, so it can, there's different procedures that can be done. The most common one is a stent, an insertion of the stent where the plaque is, and that stent, that coil opens it up. They can do laser ablation, or they can do an angioplasty. They can do an atherectomy, which means, I call it the roto-rooter, remember, removal of the plaque itself. So they can go ahead and take care of it. If the patient is not eligible for doing that interventional catheterization, then of course the patient will be considered for an open heart coronary artery bypass graft. All right, so let's say somebody has, goes for a cardiac cath, and if the access point was the femoral artery, then we know that that patient post-catheterization has to be in a prone position, straight, no bending of the legs or flexing of the legs for 6 hours. And that is to prevent any complications at the site, such as bleeding or formation of a hematoma. All right, so if they did have intervention when they go home, they will actually stay overnight. And when they go home, they will go home on an anticoagulant. Usually it's for a very limited time, for about 6 months, all right? So going home, we do need to teach them about monitoring for signs and symptoms of infection and of bleeding or formation of a hematoma. Now, the patient goes for a coronary artery bypass graft or a CABG. That is a major surgery, major thoracic surgery. So we anticipate that they are going to, they will be recovered in the ICU, and they'll spend at least their first day or more in the ICU, but they will have mediastinal chest tubes in place. We will use very, very aggressive pulmonary hygiene to prevent any pulmonary problems, since we did open the chest. Early ambulation is very important with them, and there is a cardiac rehabilitation program for them. The cardiac rehab program encompasses PT, building them up to the level that we want them to be at so far as exercise is concerned. And then, of course, they have their nutritional consults so that they are on that heart healthy diet. And smoking cessation. So whatever it is that we need to do to help them to promote their capability or their ability to lead a healthy lifestyle, healthy heart lifestyle. Okay. All right. Heart failure is the next one. What is it? It is when we do not have enough blood being pumped by the heart to meet the metabolic demands. All right. It can be either left-sided or right-sided. When we say left-sided heart failure, we mean we're looking at the left ventricle. It's the left ventricle failure that we have. When we have left-sided heart failure, which is the most common one, the fluid backup will be into the lungs. Okay, so we have pulmonary congestion, which results in shortness of breath or dyspnea. When we listen to the lungs, we'll hear crackles. The patient may be cyanotic, will suffer fatigue, confusion, and tachycardia. When we're talking about right-sided heart failure, it is the right ventricle that is failing. So we're going to have fluid backup into the abdomen, the legs, the feet, hands. So we're going to have what's called dependent edema. When we look at the jugular vein with a patient sitting, it will be distended. They may have a weight gain. They will have a weight gain, ascites, and what I call tree trunks for legs, swollen legs, and then they'll have the dependent edema in the upper extremity. So we'll see swollen hands. They will be fatigued, all right? They won't have much energy. Now, how is it treated? Well, we're going to reduce the workload. We're going to reduce the fluid overload. We're going to improve the pumping action, control any dysrhythmias that may be present, and of course administer oxygen as needed. So again, the same old drugs that we see in other conditions, ACE inhibitors, calcium channel blockers. Here we're going to add medications such as digoxin, which will slow and strengthen the contraction of the heart, so it improves the pumping action. We're going to have those beta blockers. Now remember that with digoxin and calcium channel blockers, they do slow the heart rate, so we need to check a pulse before we give them and hold it if it is less than 60. And then, of course, with heart failure, diuretics play a very important role to remove the fluid. So the medications are going to be aimed towards those goals that I told you about: reducing workload, reducing fluid overload, improving the pump action, and controlling dysrhythmias. Now, education-wise, MODS is a very good acronym to remember. It helps you to make sure that you teach on all the five important concepts for heart failure, which would be on medications, activity. We do want them to have an exercise program. And of course, with activity, we're going to teach about rest activity cycles, about their weight and what's important about weight. We also want to warn them to monitor their weight, and if they have, this is according to your EEGI, if they have a 1 to 2 pound weight gain overnight or 3 pounds in a week, they are to report it to the doctor. All right. So others, we're going to teach them about their diet. Their diet has to be less than 2 to 3 grams sodium, or even less than 2 grams. It depends on what the doctor wants to order. And of course, they're going to be on a fluid restriction, typically less than 2 liters. Symptoms, other symptoms for them to report besides that rapid weight gain is if they have any cold symptoms that are lasting for more than 3 to 5 days. All right. And of course, any of the aggravated symptoms are heart failure. But the weight gain and the cold symptoms are something that usually patients don't pay much attention to, so we need to point that out. All right, we're coming to the end here. We're coming to rhythms. Make sure that you do review what your normal sinus rhythm characteristics are. We know that it's a rate of 60 to 100, and we count the rate by counting the number of R's. The simplest way to do it, we take a 6-second strip, we count the number of R's, and we multiply by 10 to get the rate per minute. So 60 to 100 per minute. We are going to see nice round upright P waves. The PR interval is going to be anywhere between 0.12 to 0.20 seconds, and the QRS is going to be less than 0.12 seconds. Now, with lethal arrhythmias, and that's, besides the normal sinus rhythm, You will be required to know your sinus bradycardia and your sinus tachycardia, which look exactly like a normal sinus rhythm, the characteristics except for the rate, all right? The bradycardia, you know, is going to be less than 60, and the tachycardia is going to be greater than 100. So those two we do not treat unless the patient becomes symptomatic. And what are the symptoms? The symptoms will be those of inadequate tissue perfusion, all right? So lightheadedness, dizziness, they may have some chest pain, those types of symptoms. They may feel like they're going to faint. Those are the symptoms that we're talking about. Or of course, if they faint or pass out, that's syncope. Those are the ones that we treat. Now the V-tach, V-fib, and asystole, those are your lethal arrhythmias. So with lethal arrhythmias, remember your CPR. The initial actions will always be to establish responsiveness, check the airway, and establish whether the person's breathing or not. After that, if it is a V-tach, V-fib, what we're going to do is we're going to shock. We're going to shock at the maximum energy, which is 360 joules. How often do we shock? We can repeat up to 3 times if there's no response. If there's no response, then we continue with the CPR and the chemical resuscitation. Go to the antiarrhythmic drugs. With asystole, we're going to, of course, go right into CPR because the what we have for asystole is medications and CPR. We know that asystole has a very poor outcome. We're not very successful in resuscitating patients that are in asystole. We are much, much more successful in resuscitating patients that are in VFib or V-tach. So rhythms that you are required to recognize: normal sinus rhythm, sinus tachycardia, sinus bradycardia, V-tach, VFib, and asystole. All right, that wraps it up. If you have any questions, as usual, on any of the content, make sure that you email me your questions.